Well, if you have UnitedHealthcare stock like Dr. Oz has, you've probably been facing some really big losses lately. And why is that happening? Here's what's going on with Medicare Advantage.
Topics, Dr. Scott Gottlieb, former FDA commissioner, doctor, and there have been myriad complaints about some of these Medicare Advantage plans. Reading about how this works, it could certainly be rife for abuse. I'm wondering whether you have anecdotal evidence of things like this occurring. Do you understand what they're saying? That you get a lump sum from Medicare for these Advantage plans. If you find some additional diagnoses, you're able to go back to Medicare and say, you owe us more money. And in this investigation, they seem to have identified people that said there was pressure from UnitedHealthcare to push some of these obscure diagnoses that people didn't really have just to get the additional payments from Medicare. Do you know whether that goes on?
Well, look, this relates to the story that ran in December in the Wall Street Journal, it looks like, where there was a story that showed that Medicare systematically upcoded the sickness scores of patients as they transitioned from fee-for-service Medicare into Medicare Advantage. So they showed a 55% increase in the sickness scores of patients as they transitioned from fee-for-service Medicare into Medicare Advantage versus an industry average of about 30%.
Okay, wait a minute. Sounds like gobbledygook. What does this mean? It means that this is ironic. When people were on original Medicare, which means no networks, no prior authorization requirements, no restrictions, no denials of care. If you need care and your doctor says you need care, you get to go have the care and pretty much have it anywhere at any doctor in any hospital in the country because they most accept Medicare. There's no network restrictions. So if you had original Medicare, the general population of seniors is only so sick. However, ironically and magically, when those same people from original Medicare are then going into a Medicare Advantage plan for the first time, as you can see on this chart right there, they suddenly become a lot sicker. How does that happen? Or they're reporting all this stuff to the government so that the government can reimburse these Medicare Advantage companies way, 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 way more than they otherwise would have if they were just the measly old, very little sick people that were back on original Medicare. It's ironic how that works.
And for patients who transitioned into Medicare Advantage plans versus if you look at patients who just remained in fee-for-service Medicare, their sickness scores went up 7% year over year. So it looked like UnitedHealthcare was an outlier in terms of how they were aggressively upcoding patients as they transitioned into Medicare. And UnitedHealthcare, being an outlier in this regard, attracted a lot of attention when that article hit. I will say that this is a industry-wide practice. A lot of health insurers, Medicare Advantage plans, adopt different tools to try to incentivize and prompt physicians to code for things like hypertension and obesity, things that might not be noticed in the chart and not necessarily billed for. So if the DOJ goes after this with respect to UnitedHealthcare, I think it's going to send a chill across the entire industry. A lot of different Medicare Advantage plans and healthcare services providers are going to have to relook at their practices if, in fact, this becomes something that is a target of the investigation.
Well, let's hope so. And what's happened this week, Senator Chuck Grassley has demanded from UnitedHealthcare all their internal documents. Here's a little clip.
Despite these oversight efforts, Medicare Advantage organizations continue to defraud the American taxpayer, costing them billions of dollars a year. The apparent fraud, waste, and abuse at issue is simply unacceptable and harms not only Medicare beneficiaries, but also the American taxpayer.
Billions and billions of dollars overpaid to Medicare Advantage companies. And what are you getting for it? Oh, I'll show you in just a second, because that's the sickest part, really, is they're cutting your care, denying you access to doctors, denying you access to treatments, all the while profiting more than original Medicare, which doesn't have, of course, any profit in there whatsoever. If you're not yet familiar, it's probably important that you know there are two different ways you can go when you get onto Medicare for the first time, either at age 65, like most people, or under 65 due to a disability for 2 years or longer. But when you're on Medicare, you can go one way or the other, and you can either do original Medicare or you can do Medicare Advantage, which gives up your original Medicare to go to a private company who then gets to decide if you get that treatment or not. Now, if you do original Medicare, you've got access to almost every doctor and every hospital in the country that accepts Medicare, but you need something to go with that. That's called a Medigap or Medicare supplement plan, because original Medicare is only good for about 80% of it. The other 20%, you need some insurance there because there's no maximum out-of-pocket limit with original Medicare. I've helped with Medicare supplements now for 27 years across the country. Medicare Advantage, on the other hand, which we could do also, completely replaces original Medicare, parts A, B, and then D, the drug plan in most cases, so that you get to get all your care from one private insurance company who, again, is incentivized to get more money from the government the sicker that they report you to be, while at the exact same time denying that care on the back end, squeezing what's in the middle. It's called profit. With Medicare Advantage, you better have two things, or at least seriously consider it. That is a cancer insurance policy, which you can get in most states, and we've got those, because Medicare Advantage has a huge gaping hole when it comes to cancer. We'll get into that in just a minute. However, this document came from the Senate's hearing on Medicare Advantage, and I'm going to link this in the document in the description below, but check this out. One of the aspects of Medicare Advantage is that you've got to get prior authorization when you go to have things done that cost money. They don't just say, oh, your doctor says you need it. Yeah, just go get that test, go get that treatment. No, first you get prior authorization before you can have it done. And these cases here were where the people were denied, and yet they went to appeal that denial. And as you can see, overall, only 11% of people on average appealed their prior authorization decline. That means more than 88%, more than 88% of the people just said, okay, you don't want me to have that test, you don't want me to have that treatment, that's fine, I'll just live with it. Maybe I just didn't need it anyway. Well, if your doctor said you needed it, there's a high likelihood that you did. And here's the score of the companies that are out there and what they've been doing with it. Oh, but what happens if you appeal that? Look at that. They're overturned. In all of these cases, these things are absolutely overturned, which tells me, a reasonably prudent person, that if 94% of the time where they denied you care so they could just keep the profit they're making off of you, paid by the taxpayers out there, 94% of the time with Centene, as you're seeing in this statistic provided by the nonprofit Kaiser Family Foundation, they were wrong and they denied you care so they could keep the money. CVS, which is Aetna, UnitedHealthcare, Cigna, Blue Cross, Anthem, they're all doing it. And again, this is one fascinating aspect of only one thing, and that is Medicare Advantage. But it's a choice whether you get Medicare Advantage and choose to give up all this care or not. Check this out. This is an internal document provided through the Senate Finance Committee, or was it Ways and Means, where they're looking at something provided by 𝗲𝗃𝗍. What is 𝗲𝗃𝗍? We've done a video on it. You should look at it. It's the one with the big robot. This is where artificial intelligence gets to decide for you. Again, this is only an aspect of Medicare Advantage, where the artificial intelligence looks at your medical records, how private and safe is that, and then decides, well, if you need skilled nursing, here's how long you can have it for. And in this particular case, this is the case submitted to Congress, one of the witnesses before the congressional committee, and it said in this case, 16.6 days, that's what you can get. And guess what happened in this particular case on the 17th day? That's right, the artificial intelligence through UnitedHealthcare, through their app called 𝗲𝗃𝗍, kicked them out of skilled nursing and said, nope, you don't need any more. Why? Did the doctor say you didn't need more? No. Did the healthcare staff say you didn't need any more coverage? No, 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 no. What happened was the algorithm said you don't need coverage. And just because of a computer, that's why they got kicked out. And here's more of that document. Let me show you it larger. And this is hanging there. It's so funny. Our expertise, 𝗲𝗃𝗍, that's the artificial intelligence, works with your care team. No, they don't. To help coordinate your care and support clinical decision making, the decision about whether or not you get care. And that's one of the things that Senator Chuck Grassley wants to know. How many of these things are being driven by artificial intelligence, which the committee in Congress already warned them not to do it. And now it came out that they're doing it even more. And here's the big, big number. 35 million requests for care were denied by Medicare Advantage companies, Medicare Advantage only, not original Medicare, not Medicare supplement. One thing is important to note if you do go down the path of original Medicare with a Medicare supplement, guess who gets to decide on whether or not you're going to get treatment? Your doctor. Your doctor does. If the doctor says you need to be admitted to the hospital, you're admitted to the hospital. Doctor says you need an MRI, you get an MRI. Doctor says you need surgery, you get surgery. There's no prior authorization with original Medicare and the Medicare supplement company. You may be asking, well, that's private insurance too. It is, but all they do is pay the claim automatically when it's submitted by Medicare. There's not a medical director there to say, no, we're not going to pay that claim because it looks like this doctor doesn't know what they're doing. No, it doesn't happen in the Medicare world. It only happens in Medicare Advantage world. So as you can see, 35 million requests for care in this particular year were denied. 2 million of them were denied. Of those 2 million that were denied, that's a big number. That's a lot of seniors. 11% of those were appealed. 11% of the people said, wait a minute, no, I really need that. Now, imagine what's happening when you're getting that appeal going through. You're having to file the appeal by yourself, unless you've got a really good caregiver there that's advocating for you by your bedside and filling out the appeals paperwork and going through the loopholes to get that done. And you're going through either agonizing pain, waiting for treatment, waiting for surgery, waiting to be admitted to the hospital, waiting for skilled nursing, waiting for the care that gets you out of pain. But you have to appeal on your own. So that's maybe why only 11% of the people that did. But on average, over 80% were overturned simply because you did have the guts to appeal that. That's pretty sick. This is a statement I want to read to you really quick, and I'll get you to the video from some clips, some highlights of the Senate investigation into Medicare Advantage. This is from the American Hospital Association, where it says, this is writing to the Senate. This is answering the question, the Subcommittee on Investigations, looking into the healthcare denials and delays in Medicare Advantage. And it says, on behalf of our 5,000 member hospitals, the American Hospital Association, including 270,000 affiliated physicians, 2 million nurses and other caregivers, and the 43,000 healthcare leaders who belong to our organization, we appreciate the opportunity to submit this statement for record to highlight our concerns. These are the hospitals' concerns about some Medicare Advantage plans inappropriately restricting beneficiary access to medically necessary care, and we urge Congress to increase its oversight of these plans. Inappropriate denials for prior authorization and coverage of medically necessary services are a pervasive problem among certain, and we saw the list, plans in the Medicare Advantage program. This results in delays in care, wasteful and potentially dangerous utilization of fail first requirements. You got to try this first. Oh, that failed. Got to try this next. It's cheaper. Try this. It's cheaper. For imaging and therapies and other direct patient harms. In addition, these practices add financial burden and strain on the healthcare system through inappropriate payment denials and increased staffing and technology costs to comply with the plan requirements. They have to sit there. They've testified about this, American Medical Association. Doctors spend up to 40 hours a week just filing prior authorization paperwork. Many of the harms associated with inappropriate delays and denials are evidenced by the striking report issued in 2022 by the Department of Health and Human Services, OIG. Medicare Advantage plans are denying medically necessary covered services that are met with Medicare. They met Medicare criteria, and they're doing this at an alarming rate. So what that means is they're medically necessary, they meet Medicare coverage criteria, and still someone's denying them. Who's the someone? Medicare Advantage plans. That's who the someone. These problems with Medicare Advantage plan utilization management, that's what they call it. Utilization management. We're going to manage your utilization. That's what managed care is. And that's when you give up original Medicare, you go into managed care. They're managing you to get their profits. The problems with utilization management and coverage policies have grown so large and have lasted for so long that strong, decisive, and immediate enforcement action is needed to protect sick and elderly patients, the providers who care for them, and the American taxpayer who pay Medicare Advantage plans more to administer Medicare benefits to Medicare Advantage enrollees than they do to traditional Medicare programs. Who is it that's saying this? The American Hospital Association. I think they have some credibility. Lastly, says last year, in response to these developments, the American Hospital Association urged the Department of Justice to create a Medicare Advantage fraud task force. Well, guess what they just announced this week? The investigation into one of the companies, who shall remain nameless. They should create a task force to conduct False Claims Act investigations into commercial health insurance companies that are found to routinely deny patients access to services and deny payments for healthcare providers. This would ensure that older Americans receive the care that they need under Medicare Advantage, and federal dollars are appropriately spent to provide, not deny, necessary services. I'm going to show you that video. It's pretty chilling. It's a lady whose husband was on Medicare Advantage, and he died while waiting for prior authorization. He died while waiting for his appeal. He died because he was on the wrong plan. Oh, and this is the difference again. Additionally, addressing the disparities between traditional Medicare and the Medicare Advantage program is a critical issue. Well, I'm glad that Chris Westphal is bringing it up on YouTube, because there's a big old difference. Medicare Advantage. The traditional Medicare program does not use prior authorization or other utilization management techniques to nearly the same extent as Medicare Advantage plans. As of January 2023, Medicare Advantage program includes more than 30 million enrollees, way more than that now, accounting for 50% of all Medicare beneficiaries. They want those free plans. Therefore, half of Medicare beneficiaries are not subject to the type of restrictions on access to care faced by beneficiaries in Medicare Advantage. Those are the people on original Medicare. They don't have these problems. They impede progress toward equitable access to care and alignment between traditional Medicare and Medicare Advantage. Medicare Advantage only is able to survive because they get more money from the government than original Medicare does, because of the upcoding, which is the subject of the Department of Justice new investigation. They get more money, and then they deny more care. And that squeeze is the profit. We believe all Medicare beneficiaries should have the same access to medically necessary care and consumer protections that those enrolled in Medicare Advantage plans should not be unfairly subjected to more restrictive rules and requirements which are unlawful and contrary to the intent of the Medicare Advantage program. I think the intent is just to get as much money as possible. So again, real quick, and I'm going to show you that video in just a second. Medicare Advantage has within it a huge gaping hole. And this is assuming that everything is authorized. This is assuming that they're going to say yes to everything that you need done, and they're going to give you what your doctor says you need in coverage. They're going to go play it straight down the row, give you everything that you're entitled to. But do you know what's on your summary of benefits? Do you really even know? Well, here are some of the things that you may not know. Holes ahead. Hospital copay. A lot of people don't understand that as they did roll into a new year, the Medicare Advantage funding has been changed. And many of these plans have had their maximum out of pocket go through the roof. They've had their daily copay to go to the hospital go up significantly. So there's a way you can cover for that. They also don't know about the coverage big hole. And with most all Medicare Advantage plans, everyone that I've seen in the last 15 years, they want you to pay out of pocket for the 20% of the cancer treatment that's done. What? Yeah, and that's only if they approve it all. That's only if they give you prior authorization. That's only if they let you have all that treatment. They want you to still pay 20%. You can go to this website right here, and you can see how that you can plug these holes. And now that we're outside of the annual enrollment period, which is the complete chaos that goes on at the end of every year, this is the time to add these things to your plan if you have a Medicare Advantage plan. And one of the things that you'll find out is you can sleep better at night knowing that if you do have a big gaping hole in your plan, which is most likely with cancer coverage, you paying 20% out of pocket and having nothing left over because you now met your max out of pocket, which could be $7,000-8,000. And then if you roll into the new year, guess what? January 1st, your max out of pocket resets. So many salespeople will say the best thing about Medicare Advantage plan, unlike original Medicare, is with a Medicare Advantage plan, at least you've got a cap on the money that you have to spend out of pocket. That's assuming that everything that you needed was paid for by the plan. You can afford your copays at no problem, which with cancer, remember, is 20% of all the treatments you're going to have to pay out of your pocket. Again, consult your specific summary of benefits for details about your plan. This is general information about most plans out there. So what we do at the Senior Savings Network is we help explain the benefits that you have, look for possible opportunities to improve the coverage that you have, and look out for you in case things go wrong. It's important to have an advocate. And by the way, our service to do all this costs you absolutely nothing for our help. We'll just guide you along the way. In many cases, if you're on a Medicare supplement plan, that's a Medigap plan complementing original Medicare, you'll find, as we do all the time, you could have saved $100 a month on the same plan G, same plan N, same plan F, whatever you have now, same coverage, same doctor, same everything, but the premium can go way down if you allow us to shop that for you. If you find any value from this video or others, please share this video, this channel, with somebody that you know that's on Medicare or approaching their Medicare decision. And please give this video a thumbs up, would you? You have to subscribe to find out what's going on in the future, because there are a lot of changes proposed to both Medicare and Medicaid, and we're watching it right now with the government. We actually have a representative from our organization in Washington, D.C., as we speak, trying to meet with these various committees that are influencing the new legislation that's going to impact you. So you really should subscribe to the channel to find out what may impact you in the future. Again, it bears repeating. You could either go original Medicare, or you could go the road less traveled to Medicare Advantage. But just understand, with Medicare Advantage, you need to add cancer coverage if you can in the states where you can. In California, for instance, you can only do it up until the age of 65. Once you're 65 or over, the bureaucrats up in California believe you shouldn't be able to get cancer coverage anymore. It's insane. They do. But you can also add a hospital indemnity policy. What does that mean? Those big copays, it could be $500 per day in the hospital for 3 days, 5 days. So you're paying $500, $500, $500, or $350, whatever yours is. There's a very small policy for a very, very low amount of money that can pay that for you. So you don't have to go into your savings and spend your money out of pocket. If you are faced with a situation, either on prior authorization or on a treatment that you're on Medicare Advantage and they're saying, no, you are denied treatment, you're not going to have it, you can appeal. How do you appeal? That information should be readily available in your plan's documents, but you can find that information in the Medicare and You guidebook. Boy, my desk is messy. Or you can click on this link or go to this link, seniorsavingsnetwork.org/appeal, and find out how that process works. We're here to help you. We're here to serve you. If you have questions about your Medicare insurance, or you know someone who's approaching their decision to get onto Medicare, I've been educating people about this since 1990. Was it 91? Gosh, that's a long time. That makes me really old. Here's the video that I think is shocking, a clip from the Senate hearing on Medicare Advantage, and talking about 𝗲𝗲𝗱𝗏 here. Pay attention to that. That's the UnitedHealthcare company that they now loan out to other Medicare Advantage companies that helps make those decisions to deny care to save them.
Paperwork from 𝗲𝗲𝗱𝗏, I guess, had said about my husband, and then whether the reviewer agreed or disagreed.
I don't know whether you know, but 𝗲𝗲𝗱𝗏 actually relies on algorithms, not on a clinician's review, not on a physician or a surgeon examining the medical records of your husband, but on an algorithm.
Right.
And in fact, a lot of money's been made as a result of selling 𝗲𝗲𝗱𝗏 and its system from one company to another, now UnitedHealthcare, where it is a subsidiary. And you mentioned the possibility of an appeal. 35 million requests for care, 2 million were denied completely. Only 11% of those denials were appealed. But of the number appealed, 80% were granted. In other words, the vast majority of appeals were found meritorious, but only a small percentage had the wherewithal, the patience, the time, the resources, or the simple fortitude in the face of this battlefield, as Ms. Bent has described it, to actually take it to an appeal. What do those numbers tell you?
People may not know how to appeal. They may not believe they have a case to appeal. People are often very ill when they're doing this, and if they don't have a caregiver or somebody else to assist them or legal access to legal services, going through that process can be difficult. So it is a strikingly low number once you see how many are granted upon appeal. But it is striking that such a large number. And this we looked across insurers, and this was consistent across nearly every insurance firm that offers Medicare Advantage plans. They overturned a vast majority of their initial decisions upon appeal.
Striking is the right word. Actually, I think it's shocking and stunning. Ms. 𝗂𝗍𝗍, with your practical experience, what do these numbers tell you?
They confirm everything that we see on a daily basis, absolutely. We're usually involved in the bottom 80%, when clients are able to come to us and we can explain the appeal process and we can walk with them through it. If they have an advocate who's been able to access our services and speak for them and help again while they're injured or ill, and we can be that support system. But that is absolutely what we see in our practice.
And the denials, those 2 million that are then successful in being overturned when they are appealed, are often the result of algorithms. Could you talk about how you've seen in your practical experience the real world effects of these algorithms?
Right, so you mentioned the 𝗲𝗃𝗿𝗃 system and their use of algorithms. The only reason I know about the document and that use of algorithms is because of taking these cases to the federal hearing stage, the administrative law judge hearings. And it's only then when I've requested the hearing file, the case file that would have been provided by the Advantage plan, that I've seen that document. But now that I've seen it and I know what it looks like and how it's referenced, I see it referenced often in when the Advantage plans do work with a medical reviewer, a medical director. They will often reference that predicted length of stay. You'll see the acronym PLOS. And you'll also notice it too, it's decimal points. So-and-so is predicted a predicted length of stay of 16.6 days, and they'll receive the denial on the 17th day, and we see that repeated.
In fact, I'm going to hold up a document that I'm going to ask to be included in the record without objection. It refers to a anticipated stay in length of days of 16.6, and that's the date, in fact, on the 17th day when, in one case you were handling, a discharge resulted. Does this reflect your experience?
Yes, it does.